And next we have Dr. Akshay Nair, who is going to talk to us about the 3D surgical simulators, virtually perfect training for the beginners.
All right. So I'll be talking about 3D surgical simulators, virtually perfect training for beginners. These are my financial interests. I am associated with Help Me See, which is a company that is in the domain of simulation-based training. So this is a brief overview of what I'll talk about, the different types of simulation available in the ophthalmic sphere for training, the types of simulators, the way we can assess whether simulators work or not, and finally, what evidence do we have. So there are simulators available based on the type of skill that is intended to be taught. It could either be a clinical skill in the clinical room, in the examination room, like gonioscopy, indirect ophthalmoscopy. It could be a surgical skill like cataract, vitrectomy, or other surgeries. So there is different types of simulators. There are model eyes with microanatomy of the eye built in, which gives you the same kind of image like a retina fundus when you see with the 20D, that is the retina. You have the simuli, which also works as a good target for lasers. You also have the IC indirect ophthalmoscope, which is a head with different types of pathologies that you can see, as well as different types of pupil sizes that can train you in how to use an indirect ophthalmoscope well. So similarly, on the types of simulators that you can have animal models, you can have human cadaver models. See, at the end of the day, every simulator is not a high-tech piece of gadgetry. Any task, object, or process that mimics or simulates the actual surgery or the procedure is a simulator, which is why using even a cellophane tape or an IOL box to practice capsulorhexis is a type of simulation. And all of those would come under the inanimate objects that we have. And finally, we come to virtual reality, which I'll speak about in depth. So we typically hear the word wet lab and dry lab, etc. The reason why we use the word wet lab is because they use chemicals or tissues that can be wet hazards. So typically what we use is human eyes or animal eyes. This is this paper by Bharti et al., where what they did was microwave a goat's eye for 30 seconds, the heat induces a cataract, and then they go in and try and practice cataract surgery on that. You can use vegetables, fruits, or bits of both tissues like tomato peels, etc. Inanimate or artificial models such as this, which is the Kitaro eye, are very popular. You can create an artificial anterior chamber where you inject it with viscoelastic, and this has a very good visual feel as well as a tactile feedback to do a task like capsulorhexis. But as you can see, the moment you've done one capsulorhexis, that entire lens model is now not usable. So a high requirement of inventory of these eyes is needed, especially for trainees who are prone to making errors. So if only there was a way where you could have an unlimited supply of eyes or training material, and that's where something like a simulator, a virtual reality comes in. This is Vitret Eye, which is a Philips-based model for vitrectomy. And of course, dry lab training where there is no spillage involved, like I mentioned, an IOL box or a Rexus forceps on a taut aluminum foil. All of them work as well to train some amount of skills needed in the real OR. But how do you know whether it works or not? So you really need to assess the performance on a simulator to know whether it actually correlates to real-life surgery. So there are two ways of doing this, cognitive skill and technical skill. Without going too much into detail, there are different rubrics and models that are already created that can help understand whether a trainee who is operating on a simulator is doing it the right way, which is called the SIM-OSCAR. And there are different papers that have been published that have shown whether it works or not. Now, when we come to virtual reality simulators, these simulators themselves have a inbuilt scoring and assessment. This is the scoring system of the IC simulator, where unless you reach the level 1 and do a task well enough, you don't go to the next level. Now, this is the inbuilt scoring and assessment of the Help Me See simulator. So here you can see that the trainee is performing a task, and the number of errors that he's doing, say for example, zonular damage, all of these are being calculated, and the inbuilt system itself will tell you whether it was a satisfactory attempt or not and grade you. So you don't even need an instructor to be there. And the advantage of a virtual reality simulator is that there's no worry of collateral damage. You can do a capsule or posterior capsule rent 100 times without worrying what is going to be the effect on the patient, because you're not doing it on a patient. You can learn, relearn, unlearn, and do that everything again and over again. You may have done 200 cataract surgeries, but you may not have had a rent. And that first rent that you have, you don't know how to react. But if you've prepared by doing it over and over again on a simulator, then you're much better prepared when it happens in real life surgery. So the Help Me See surgery simulator is available for SICS, for phacoemulsification, for complicated scenarios like putting in a CTR, anterior vitrectomy, and for scleral suturing. How does it work? It has it is designed to resemble a patient, and you've got haptics or handpieces through which, and what you see through the microscope is the eye that you see on top. And you can see the surgeon here wiggling his hands, which is basically the crescent going through the scleral tunnel. It has a 3D visual that you see, and this is the assessment. I think we already went over this. Similarly, for phacoemulsification, this is trenching happening, and it has a foot pedal, so you also learn hand, eye, and foot coordination. You need to know exactly on which mode is irrigation, how do you go into aspiration, how do you change the power settings. And there is always an instructor who sits by you doing training, helping you train. You can see that these are hyper-realistic visuals. They are 3D visuals. It gives you real-time feedback, which means you get the actual sensation of touching an eye, the virtual eye there. And it's got an AI-based scoring and one-on-one learning with feedback. And the Help Me See simulator is now available for training in India. There are multiple installations, including LV Prasad and Arvind Eye Hospital, Madurai, where external trainees can come in, learn on the simulator, and go back. But does simulation-based training really work? Here I am talking about simulator, but does it work? There are actually many studies that have shown that ophthalmic surgical simulator training improves the performance of capsular access. So in this study, they had a group of trainees perform capsular access. They had a 15% complication rate. They learned simulation capsular access on the simulator, and their complication rate went down by 50%. Again, this is a paper that showed that assessed the complication rate of surgeries done by trainees who've trained on the simulator versus those who have not trained on the simulator, and there was a 50% reduction in posterior capsular rent rates if you've trained on the simulator. Again, this was a paper that we had published about how if your performance in real life correlates with the performance on the simulator, which means that the simulator mimics the actual human eye while you're performing on it. The same thing, efficacy of the IC simulator in training improves high tension capsular access performance, and this was also published in the Nature group. I was the co-author of this, which is this was a study that we conducted in India with LV Prasad, Shankar Netralaya, and Mahatma Hospital, where we had a group of trainees who came to Mumbai, underwent simulation-based training, went back to their surgery, to a parent institute, and their first 20 surgeries were recorded. Similarly, there was another group of trainees who did not learn on the simulator and did live surgeries, and their first 20 surgeries were also recorded. The first 20 surgeries of surgeons in both groups were masked and seen by observers who did not know which video was seen by or was performed by whom, and they did an analysis. They saw that these are each of the errors that you see now. The control group is the group. The orange bar is the errors by trainees who've not learned surgery on the simulator, and the blue is the errors by trainees who've learned surgery on the simulator. Every single error was quantitatively lower by the simulation group than the non-simulation group. Major errors, minor errors, and errors overall, you can see that they are significantly lower in the simulation group. The learning curve is much more steeper in the non-simulation group. So overall, at the end of the day, when there are better surgeons being prepared by training them on the simulator, it is going to translate to better patient safety, because at the heart of whatever we do is patient safety. So to summarize, we have different assessment tools to know how trainees are performing on a simulator and to see if the skill that they learn on the simulator translates to real life. Simulators allow trainees to be in a stress-free environment. Complications are no longer the trigger of stress that they used to be. There is no collateral damage to patients. Patients don't undergo trauma that a trainee operating them would normally cause if they've learnt on the simulator. There are clear long-term benefits, and the advantage of simulator is you can have customizable scenarios, and at the end of the day, like I mentioned, we are all focused on improving patient outcomes, and that is the direction that we're going. Thank you for your time. And if you all are interested in the trade area Hall B, the Help Me See simulator is on display for you all to take a demo of it and see how it goes. Thank you so much.